Okay, so we are live. Can anyone hear me? If so, please write in the chat. Great. So for the people that are present, I will do a next one in 2 weeks. So if you have any topics, then that you have problems with them, then write them in the chat. We can discuss them next time. Also, shout out to Lucas. Okay, we'll start in kind of 3 minutes to see if we will have other students. Okay, let's start. So this course is made to provide you some value for your upcoming Step to CK. Now, I want it to be more applied, so I won't just tell you what to review and what to prepare for Step to CK, and we will delve directly into the vignettes. I strongly suggest that you write in the chat the answers and the explanations. We will tackle each one like this. And since we are less people, it will be actually more productive to talk about them. So, let's start with a man. He has 55 years old. He presents to the medical office complaining of a retrosternal chest pain that appears when he climbs a flight of stairs to walk into his apartment. Every time he has to rest in order to experience relief from the pain. From the medical history, what is important is that he has orthopedic prosthesis, hypertension, diabetes mellitus, and the left bundle branch block. His last echo was done a pharmacological stress test. We will follow up with a cardiac stress test. We put him on nitrates, or we do a coronary angiography. Okay, so pharm stress test is one answer. Also, I have to mention that it will be a delay of 30 seconds between your answers and mine. So this is why sometimes we are not aligned. I hope you know that. Okay, so indeed he cannot run, but in the same time he has a left bundle branch block, meaning that any EKG is out of question. More importantly, he has an ejection fraction that is low, so any other stress on his heart won't be sustainable. If we consider the risk assessment for coronary artery disease, we'll observe that he's in the high risk class. Therefore, he needs a coronary angiography. Now, how do we calculate this pretest probability for coronary artery disease? Our pretest probability can be considered low, intermediate, and high. Low is for the men that have less than 40 years or the women with less than 60 years that have a non-anginal chest pain. Also, the low class includes atypical angina in women less than 50 years of age. For low risk patients, we will consider cardiac exercise stress test. The intermediate population is represented by males that are more than 40 years and females that are more than 60 years. They have non-anginal chest pain. If we have a patient with atypical angina, then we consider him intermediate if he's or she is more than 50 years. Or in the case of typical angina, we consider the males that are more than 60 years, or females that are more than 40 years, less than 40 years. The approach is the same. We go for the stress test. If the patient cannot exercise, we do a pharmacological stress test. In high risk patients of coronary artery disease, we consider patients that have typical angina and that are males. They are more than 40 years, or in females that are more than 60 years. The same approach, cardiac stress test, pharmacological stress test if the patient has problems with his EKG, or if the patient cannot exercise. And if those two above are not possible, then we go for coronarography. Lucas, still there? Yes, normally we would go to the farm stress test, but he has an ejection fraction that is really low. So we can't use dobutamine or adenosine to induce other complications. Superb. Do we go further? Yep. Okay, now that we discussed about atypical angina and typical angina, how do we differentiate them? Symptoms. Okay, but this is more like unstable angina and stable angina. The stable angina occurs not at rest, and an unstable angina starts to develop also at rest. I think it's better to ask, how do we define a typical angina? What are the components of a typical angina? Okay, so a typical angina has three key elements. Firstly, it is relieved with nitrates or with rest. Secondly, it is a retrosternal chest pain. And thirdly, it is caused by exertion or stress. Atypical angina, on the other hand, fulfills only two criteria. Some patients that usually have atypical angina are the patients with diabetes. They might present with retrosternal chest pain, and also it would be caused by exertion. More frequently, the diabetic patients lack the chest pain component due to the dysautonomy induced by hyperglycemia. The non-anginal chest pain fulfills only one criterion from the above. So, was this case clear? Exactly. Exactly, Lucas. So 1 out of 3. Okay. Now, the next case. A female of 23 years old comes to the ED with palpitations, stating that she coughed blood. 3 weeks ago, she was diagnosed with gastric carcinoma. The patient has 37 degrees Celsius, 120/80, and 123 beats per minute. What is the best next step? CT angiography, D-dimers, ventilation perfusion test, or streptokinase? Okay. Is also Apple Jones present? Has to say what's his opinion on it? Okay. The key info is that she coughed blood, that she was diagnosed with gastric carcinoma, and she's tachycardic. Per Wells criteria, this means she has 3.5 points. when having a pulmonary embolism, we evaluate the probability of having a pulmonary embolism based on Wells criteria. If the Wells score is less than 4, then we will opt for D-dimers due to their higher specificity and lower sensitivity, as well as their cost efficiency. It is right, we do a CT angiogram, but if the Wells score is above 4. I hope I'm not interrupting myself. So, CT angiography is done if the Wells score is greater than 4. We choose D-dimers, they have high specificity, low sensitivity, and per Wells criteria we have a score of 3.5. Now, in this type of question, it is important to know the Wells criteria. The Wells criteria for pulmonary embolism are hemoptysis, 1 point. Malignancy also gives us 1 point. If the patient has a history of previous DVT or PE, he will score 1 point more. If there was a history of immobilization of previous surgery in the last 4 weeks, we will add 1.5 points. If the patient is tachycardic, we add 1.5 points. If there are clinical symptoms of DVT, we add 3 points. And if other diagnosis other than PE is less likely, we also add 3 points. Could you tell me some clinical symptoms of DVT? Sex doesn't matter. I don't understand, but what do you mean by how do we get to 4? Right. Cuff pain, indeed. Oh, how did we get to 3.5 in the patient's case? Okay, let's go back. So, the patient has 123 beats per minute. She's tachycardic. This means 1.5 points. The patient was diagnosed with gastric carcinoma. This is another point. And she coughed blood, which is hemoptysis, for 1 point. Indeed, symptoms of DVT include symptoms like cuff pain, leg erythema, the medical history in the case of DVT might imply a long flight, immobilization, Exactly, hospital setting. Now, how do we approach the diagnostic? If the Wells criteria is less than 4, we go for D-dimers. If it's negative, then we exclude pulmonary embolism. If it's positive, we continue with the other test. The other test is also made if the Wells is above 4, meaning we will do a CT angiography. Lastly, if the patient is pregnant, we opt for a VQ scan to avoid exposure to radiation. So, was this case clear? Do we have questions? Okay. A 65-year-old patient is prepared for an elective splenectomy due to persistent ITP. His medical history contains chronic kidney disease, asthma, and an appendectomy in his early adulthood. His labs will show 50 grams per deciliter hemoglobin, a normal CBC, 4.5 potassium, 137 sodium, and a creatinine of 2.6. Which test is indicated for the preoperative cardiovascular risk assessment? Echocardiography, an EKG, or a stress test? Exactly. We will go with A. Sorry. We will go with an EKG. This was a close one. The correct answer is an EKG because the patient has one revised cardiac index factor, and he's more than 65 years old. For Lucas, so we can, with the EKG, we can see structural anomalies such as hypertrophy. Now, to better understand why we do not choose echo over EKG, I'll go further. The revised cardiac index risk the revised cardiac risk index has 6 factors. The factors that are from the patient are 5. There's a history of stroke or TIA, a history of congestive heart failure, an insulin-dependent diabetes mellitus, a creatinine over 2 milligrams per deciliter, and a history of ischemic heart disease. The other factor is represented by procedures. If the procedure is intrathoracic, abdominal, suprainguinal vascular surgery, then we have another factor added. We choose EKG as a pre-op cardiac screening if the patient has more than one risk factor and one of the features such as COPD, age greater than 65 years, arrhythmias, or peripheral artery disease. For the echo, the patient has to have a history of valvular regurgitation of stenosis and no echo in the last 12 months, and exacerbation of cardiac symptoms, namely SAD, syncope, angina, and dyspnea. Lastly, for the cardiac stress test, we need a patient that has poor functional capacity. He's breathless on a flight of stairs. He's breathless on a flight of stairs and has more than one risk factor. Now let's go back and answer the question of why not A. So this patient has a history of asthma, CKD, and appendectomy. Neither of them are indicative of any risk factors for cardiovascular pre-op evaluation. However, he has a creatinine of 2.6. We would consider echocardiography if he had a history of stenosis or regurgitation and we had no echo on him, or if the patient had actually any cardiovascular symptoms before the surgery. Okay, so no questions on this one. let's discuss a little bit the difference between left bundle branch block and right bundle branch block. What is the difference between left bundle branch block and right bundle branch block? Lucas, what is the difference in the EKG findings regarding left bundle branch block versus right bundle branch block? Indeed, in the right bundle branch block we have an RSR prime, right, and the bunny ears. Yes. Just to mention that in the right bundle branch block we have in V6 a slurred S wave. Okay, so any new left bundle branch block will raise suspicion of a STEMI. The criteria for left bundle branch block are M sign of R wave on V5, V6, a deep S wave in V1, V2, and a QRS of greater than 120 milliseconds. This is how a left bundle branch block looks like. As we can see, there is also a peaked T wave that prompts to a possible STEMI. However, without labs such as troponins and CKMB, we cannot diagnose a STEMI. The peaked T wave can be just secondary to the left bundle branch block. For the right bundle branch block, the criteria are an error SR prime in V1, V2, a prolonged S wave in V5, V6, and again, the QRS complex is greater than 120 milliseconds. This is how a right bundle branch block looks like. We can see the aspect of error R SR prime on V1. Also, we can see in V6 the slurred S wave. Do we have any questions? Do we have other questions that are related to cardiology but not to this course, such as problems that you have with different cardiology? So, Lucas, you recommend to post in the same day, in an hour before. Okay. You mean to post it on the Facebook group, right? Rheumatology, okay. Just rheumatology or other subjects? Do you also have any other feedback, Lucas? By the way, thank you. You've been so great in interaction. I hope it gave you some value, this course. Okay, then for the next time, I will see what I can do for rheumatology and MSK. If you're not subscribed, I recommend to subscribe to the channel. And also, if you know people that would actually benefit from this type of courses, let them know. And maybe this way they can benefit also from the content. Bye, and thanks again, Lucas. Great interaction.